Hello, I'm Amy Sheffrin. I'm pleased to welcome you to the New York State Health Foundation. With Halloween around the corner, it's particularly apt to be talking about unwelcome surprises. Some of these medical bills can be a fright. In 2014, New York State enacted the first in the nation protection from surprise bill. Since then, the issue has received growing attention around the country. By late 2017, over 20 states had instituted some sort of consumer protection against surprise bills, but they often came with significant limitations. Researchers like our panelist, Lauren Adler, had identified the need for a federal level intervention. And recently, a bipartisan work group in the U.S. Senate released draft legislation to address surprise bills at the federal level. So there is a lot more to come at the national and state level on this issue. And our panelists are here to shed some light on society and has been a leading voice in spotlighting these issues and advocating for reforms. Lauren Adler is the Associate Director, USC Brookings Schaefer Initiative for Health Policy.
Hi, everyone. Everyone can hear me? I'm close enough to the mic? Good. So I'm with the Department of Financial Services, Doctors, Medical Society, etc. And it was a real team effort. And I did want to recognize Emily Donovan, who's here, part of my staff, who worked, was a key drafter of the legislation, along with some of the other members of the team. So I'm going to first spend just a couple minutes talking about a few of the key problems and provisions in the law that this bill addresses. But I will say it has served as a model for much of the rest of the country. When it passed, we did two presentations at the National Association of Insurance Commissioners. I've been working, and Emily and team have been working with staff from several, I would say a couple dozen, certainly, states that are actively interested in this. We did a webinar with the Consumers Union, and I'm actually going to be speaking on Thursday to the National Governors Association about our bill. So it's been the model for a number of people, and I just want to give a shout out to Magda Shaler Haynes from New Jersey. Came here, they just passed one, and maybe she'll share some comments with us, but former department staffer and excellent person. So I'm going to start giving out just a really high-level overview. I know there's a bunch of familiar faces, and so this will be high-level review for some of you, but I've heard that maybe not everybody is familiar with some of the pieces of the law. And then we'll talk a little bit about how it's working, what the implementation has been like and what the experience has been like. So when we look at kind of what prompted this, clearly surprise bills was at the heart of it. That consumers doing everything they could to stay in network, but nonetheless get a bill from a doctor that's out of network. And I remember when my old superintendent, Ben Lawsky, came in, he said, "Troy, what's the biggest problem facing consumers?" And without skipping a beat, I said this. And so we really wanted to solve this. And what we needed to do was take consumers out of liability. And that's at the heart of this bill is consumers are taken out of liability for any emergency room bill, like any emergency room bill, as well as any surprise bill from an out-of-network physician. So in those two instances, the consumer's held harmless from liability, and that claim is submitted, at least for surprise bills, and emergency bills from a physician are submitted to an independent dispute resolution process if what the insurer pays for the doctor is not, they don't agree. So it's sent to an independent dispute resolution process. And when we were crafting the bill, what was really important to the doctors in particular was it had to be speedy. So we set a really tight time frame for the IDR dispute. So from the time it's received, it all has to happen within 30 days. And to try and get these bills to be surprise bills and disputes in particular about them to be less frequent, we did a baseball arbitration concept. So the insurer pays what they think they should pay, the physician bills what they think they should bill, and that is the IDR, Independent Dispute Resolution Agent, who's an independent entity certified by us at the department. That entity has to decide which is more reasonable, the bill from the doctor or the health plan's payment. And the idea behind that is it keeps it simple. You don't have all this back and forth, but it also, in the first instance, hopefully the doctors will bill reasonably and the insurers will pay reasonably to try and come to a middle ground. So that's a little bit about IDR and the protections. Another issue that we were faced with is comparison shopping for consumers. And Magda and I actually did a law review article about the importance of being able to comparison shop, the importance for markets. One of the things we had heard, I speak sometimes at chambers of commerce, and I'd have people come up to me and say, oh, my out-of-network insurance just got better. It went from 80% to 120%, and what they didn't realize was that it was going from 80% of the usual customary rate to 120% of the Medicare rate, which is actually less. So there wasn't really good effective disclosure. There's a series of improved disclosure requirements, and I won't go through all of them, but that was an important piece. And also, when consumers are using services, there was a series of disclosure requirements around health plans, hospitals, and doctors to try and improve the ability of consumers to understand what the likely bills are that they're going to be facing. It would take a long time to go through all of those provisions, so I'll just leave it, but if anyone has any questions, I'm happy to go through them. And there's a whole bunch of slides on the back of this that go through all of that, and I'm not going to go through into all those details, but that was another important feature of the law. Another huge important feature of the law that we were trying to get at is network adequacy. And I think the bill in general shows we want to protect consumers and even providers around out-of-network coverage. We absolutely want networks to be the solution for consumers. It's always cheaper to go in network, and it's something that we want to promote. We want to promote more usage of networks. So we tried to address some of the missing protections. We extended the network adequacy review that used to be just with the health department on HMOs, which is about 15% of the commercial market. It's now been extended to the rest of the commercial market, the non-HMOs, which is about 85% of the market. So now the Department of Financial Services, using the same standards that the health department uses, we do a network adequacy review, and there's a whole bunch of provisions around that. Again, I won't go into it unless somebody asks me about it and wants to. But in addition, we had a safety valve provision, access to out-of-network care at the in-network cost share. And so the law protects, if notwithstanding our review, consumers facing a situation where they need out-of-network coverage and there's not an appropriate provider in-network, they can go out-of-network at the in-network cost share. Now, if there's a dispute with the health plan says, no, your in-network coverage is fine. That's essentially a medical necessity question. Medically, do you need to go outside of the network? We have an external appeal process, a new external appeal process that consumers can go to an independent doctor and get relief on that, and it's binding. So in addition, we had provisions regarding reduced coverage for out-of-network benefits. One of the things we found, we did a report that's on our website, I believe still, an unwelcome surprise, and we documented that huge bills from out-of-network providers, we had a big issue with reduced coverage for out-of-network benefits. And so what we required is that insurers make available at least one benefit so that in particular groups can buy it using the UCR, usual customary rate, with Fair Health, which is the independent entity that looks at provider charges at the 80th percentile of Fair Health. So at least one benefit needs to be available in each market, and there's a provision in there that the superintendent reviews to make sure that that's available in the group market every year. And if it's not, the superintendent has the ability to require it. So far, we've not had to do that because there's always been at least some coverage available for consumers. And then lastly, difficulty in submitting claims. Not all plans had, many did, but not all plans had electronic claim submission available to consumers, and so this bill required that. So those are some of the key. Last one is that there was a work group, and we had the work group and came out with a bunch of recommendations. You can see it online, and I think Elizabeth will probably be getting into some of the possible changes or improvements that we can build on, and I think Lauren will talk about some other states are doing. But those are some of the key provisions of our law, and I'm just going to zip through and just do two more slides and to kind of talk about how coverage has been going, and in particular the IDR process, the independent dispute resolution process, how that's been going. And you can see on this slide, this is since the bill was enacted up to the most current we had, which is like this summer, that we had a total, it broke it down by emergency and surprise bills. I'm not going to go over all the numbers, you can see them, but I think some of the things that were interesting is that in the emergency room context, the health plan definitely prevailed more often. In the non-emergency surprise bill situation, the provider prevailed more often, but a lot of split decisions, and also quite a few settlements reached between the plan and the provider. So I'm happy to hear, I know there's a lot of experts out here in the audience, and look forward to hearing from you. I would say in general, what I'm hearing mostly is that the bill's working, that for what it does cover. I think there's some areas that Elizabeth will talk about where we may want to discuss expanding the bill, but where it is applicable, it has really been working. We've seen the number of complaints drop off, and there's been more coverage for consumers as a result of the bill in a pretty dramatic way.
What's the time span of this?
So this starts from when after the bill was passed, so it goes in 2015 really. So it's 2015, 16, 17, and about half of 18. Should have put that on there, but. And then just to see, this is a slide that just shows where we're seeing a lot of the IDR disputes. And I think you can see on the emergency side, not surprisingly, a lot of emergency medicine complaints, as well as orthoscopic surgery and a lot of plastic surgery. And then on the surprise bills, it's a lot of neurosurgeon, anesthesiologist, a lot less plastic surgeon. So that's just what we're getting. So that's kind of my brief overview. I know it was pretty high level, but look forward to hearing questions.
Thank you, Troy. We're going to get Elizabeth set up and her slides, and while we do, I'll ask you a few questions. So the New York law, as you pointed out, had some other consumer protections.
My cell phone. It's good to some information.
Yeah. So the New York law had some other consumer protections, as you mentioned, besides surprise bill, such as you could have this potential, for example, to go out of network if there's no adequate provider within your network. So I'm just curious, like, how is the uptake on those other provisions, and how would a patient have to demonstrate? You alluded a little bit to this. How would they have to demonstrate that there's no adequate provider in network?
So, I can give you some numbers. So for 2016, we had 28 appeals for the external appeal. For 2017, it was 23, and for 2018 so far, 16 appeals. And we can talk about how many were, what the ratio was of success on those. But generally speaking, what a consumer needs to show is that the in-network provider is not appropriate or adequate. So how do you do that? Well, as a practical matter, you're almost always going to need your treating physician to help you out with that and to provide evidence for why that is. So I'll give you one example that I remember helping out on. There was a kid who had to have, who was undergoing a really specialized kidney procedure, and the specialist who was going to perform the procedure had done it. It wasn't not a common procedure, but had done it about 24 times on adults, but had never done it on a kid. The treating physician had done several hundred on kids, and we made the argument, with the patient that wasn't appropriate, that the out-of-network doctor was appropriate. They didn't have somebody who they offered with appropriate level of experience. And I want to be really clear, appropriate doesn't mean the best, right? So I would be really clear about that. It doesn't mean the best. It just means a doctor who's appropriate, who has had adequate training and experience to handle the particular procedure. And then ultimately it's up to the IDR to make the decision, an independent physician to make that decision.
Thank you. I'm going to ask another question. I see Elizabeth's ready to go.
No, I'm totally not. I'm fascinated.
Okay, so I was also just thinking, part of what drove the 2014 law was the number of consumer complaints that you saw. You had said part of it was, you were responding to what consumers were saying. But we see that not a lot of people even know that they can submit formal complaints. And, in this national survey, Consumer Reports found that 87% of people, Americans around the country, don't even know where to turn, what agency to turn to with health insurance problems. So instead, they often call their health plan as a first resort, and then as a last resort, they don't know there's any other channels. So are there ways the state or DFS can bring more visibility to the calls that the health plans are getting, so we can kind of see what issues are emerging from that pool?
Well, certainly not going to stand here or sit here and say that notice is perfect, and really open to any ideas anybody has on how to improve it. When we were sitting down and trying to figure out how to implement the law, our thought was, well, where are the consumers going to be most focused on this problem? At what point in time, and what information can we get them? And the consensus, rightly or wrongly, was when they get a denial notice. So in the denial notices and the EOBs, plans are required to give notice of your appeal rights, that you have a right to this external appeal. Whether that's enough, whether people are really reading those statements, is a question. And right. And the other thing is, about 50% of the market, it's in the mid to high 40s, are in self-funded ERISA plans. Those self-funded ERISA plans are completely insulated by virtue of federal ERISA law from any state regulation. So as a result, all of these great protections that we've been working on for the state don't apply to nearly half the commercial market. That's a huge problem. It's something that's at a federal level, and so any of our requirements around notices and EOBs don't apply to those ERISA self-funded plans.
Thank you. Okay, Elizabeth,
I'm not gonna
you're,
look at you because you're gonna say.
you're up. And can you pass the remote?
Okay, hi, okay, I thought I was gonna be able to handle that, but I'm not. Okay, hi. No, I'm good, thank you. So my name is Elizabeth Benjamin. I work at the Community Service Society of New York, which is a 150-year-old, 175-year-old New York philanthropy. It's dedicated to fighting for people who are low-income or moderate-income folks and trying to bring their voices into the policy conversations that we all have. One of the great programs that the Community Service Society runs in partnership with New York State Department of Financial Services and the New York State Department of Health is the Community Health Advocates Program. And what we do is we're under the federal law, under Section 1002 of the Affordable Care Act, consumer assistance, the state had to designate a consumer assistance program that would help people with their insurance problems as more and more people became enrolled in coverage. And so we're really lucky that New York State did a procurement and procured community health advocates. And since 2010, since the enactment of the law, we've helped 337,000 New Yorkers. It's around 30,000 folks a year. About 10,000 people a year we call our Live Answer helpline. It's open from 9 to 4, Monday through Friday. We don't really have enough resources to have it after hours or anything. The grant is not as, it's great, but, we could always use more resources if anybody's, dying to fund consumer assistance. But it's really great. It's really made a big difference in New Yorkers' lives. And every year we're basically saving them, last year, almost $6 million in medical debt, which is a real burden on folks to suffer through with medical debt. We know that from all the polling. So that's just a sense. It's a really great, we do have a Live Answer helpline, but our model also is to fund community-based organizations. So we have real boots in the ground folks in the communities that we're serving, because a lot of people aren't comfortable talking to someone on a phone and really want to talk to someone face-to-face when they have a problem. So, I guess I wanted to just remind people about why we needed this surprise bill law in the first place. And this gentleman, Angel Gonzalez, was a client of ours. He called us, he lived in Long Island. His income was about $18,000 a year. He was a graduate student, actually. And he had an emergency gallbladder surgery. He was in severe pain. It was an emergency procedure. He went to his in-network hospital, so he knew where to go. And it turned out that the surgeon and the surgeon's assistants were not in network, and they charged him $30,000 each, $60,000. The guy makes $18,000 a year. So he was surprised, to say the least, and came to us after losing on his own with the plan, and we were able to get him knocked down to, I think, a $375 bill after a bunch of haggling and negotiating. I just want to say that United did pay $1,200 on the $60,000 bill. Actually, they said it was worth $1,200, but they paid $800. Medicare said that the bill should have been for $900. So you can see that this $60,000, the huge discrepancy between what our charges and and negotiated charges is can be quite broad. So he was pretty happy and was willing to be profiled in the New York Times. And I think this story is one of the many stories that helped us get this law enacted. I did want to say, and I can't, of course, read that, so I'm going to just read from my. The law has been enacted, but consumers are still really troubled by surprise bills. They're still getting them. NORC did a great survey that said, 40% of consumers skipped treatments in the past year due to cost concerns. 50% of Americans say that they received a bill for a cost that they thought was covered by insurance. So I think it's still a live issue for folks, but maybe less so in New York State. And let's see why. So we went through our data and we reviewed 208 cases. So not as many as Troy's shop gets, for sure, but these are cases that we've touched and we know each consumer pretty well. And it involved the surprise out-of-network bill since 2015. And around 57% were related to emergency and surprise bills. Some were, but there was a big tranche that were related to incorrect information, 35%. And then tiny numbers, but I think we're seeing these grow, is out-of-network ambulance services are not covered by this law, which is a big problem for consumers. And because, you don't actually get to call up 911 and say which ambulance service is coming to you. It's just whichever one they send. And that's a problem that should be covered under the bill. And then border county physicians. So we have one of our partners, actually, Beverly Chin from the Health Planning Council, which is a subsidiary of the Human Services Council of Tompkins County, so we're talking pretty far west in New York, called us up. And what they're seeing in the southern tier is a lot of physician groups are now joining Pennsylvania hospitals, northern Pennsylvania hospitals, and they're sending their patients there, and people are getting stuck with out-of-network bills from Pennsylvania unwittingly. That, of course, would be covered under our statute if they had gone in state, but of course, no one's telling them that. So just to move along a little more quickly, because I'm sure I'm taking too much time. So this is the great news. The law is working for 68% of the consumers that call us. So that's just awesome. So the classic anesthesiologist, you wake up and your anesthesiologist, those guys, done. We don't have that problem so much in New York State anymore. So that's the good news. The bad news is that, here's our little ambulance in the left side, and on the right side is these border county states. So I think, if we got a magic wand and reopened this bill, we would say, please do these two issues while you're at it. And then the biggest issue that we've been really quite concerned about since the enactment of the law is the 35% of the consumers who say, hey, my doctor, my health plan, it's right here on my health plan's website. They say my doctor or surgeon's in network, but after I got the procedure, they're not. So it's inaccurate listings on either the plan website or the doctor, says, oh yeah, I'm in Empire. Guess what? Maybe you're an Empire EPO, but not PPO, or you're an Empire EPO, not HMO, and that's, no, I'm only picking on you, Sean, because you're in the audience, I'm sorry. But, people don't, the point is that, almost all carriers have multiple product lines, right? And so it's easy to get confused as a consumer, or certainly as a provider office sometimes don't really understand as well as we would like that, they may not take that exact product. So we're seeing this quite a lot for us. And the provider gave incorrect information about 35% in 35 cases, and then in the 47 cases, it was the plan. So it's pretty evenly split between the two, with a slight little more of the plans stuff. And so, we brought this problem to New York State, and, we are so lucky in New York State to have such wonderful partners that are willing to work with us at the regulatory level. And so they've done some just extraordinary things, really important things. First of all, the New York State of Health launched this provider and health plan lookup tool, so I'll come back to that, but that's pretty cool. And the insurance law was modified to say, look, plans, you have to update your websites within 15 days of an addition or termination of provider. We're sort of having some, this is still an issue, I would say, so I'm going to come back to that later. And then in 2016, the New York State Health Plan Invitation, so again, this is for plans that want to offer on the exchange, which is, covers around 300,000 people in New York. It has to have a directory dispute protocol, and so we'll talk some more about that. And so there's some other, protections there, which are really great too. But let's go through. So the first one is this lookup page is really helpful for consumers, because this is probably the best data you can get. This is, the health plans submit their data, and you can search. You can go right onto the New York State Health website and search by your doctor, by your hospital. I have two little kind of gripey things about this. My first one would be, when you type in NYU hospital, you get, I think, a response, 263 responses, so it's really hard to figure out which portion of NYU hospital actually is in network or not. So if there could just be at the top saying, well, most of it's in, or the fact that the hospital, it's like a little confusing. So that can be a big search chore for the person who runs the search. And then, my personal primary care doctor, Dr. Kyle, who I love, who is actually affiliated with NYU, she is really frustrated because she moved her practice 3 years ago from 14th Street when she was with Beth Israel to NYU, and unfortunately the plans have not kept up with her, so she's still listed with Cigna, Travelers, Nippon, Delaware, and United at that 14th Street location, and many of her patients are quite upset But the good news for Dr. Keel is that she can actually, what she did is ask me to do this for her. And before I get back to my annual physical, I really got to do this for her. She, so I just don't have her. I think there's some kind of doctor ID number, so I got to get that from her. But anyways, I can go in and report that she's incorrectly listed with those 5 health plans. So I plan on doing that any day now, Dr. Keel. Don't be mad at me. But that's cool. You can report it. We're still finding, though, that said, we had some interns. We're still getting a lot of consumers complaining about the directories, and so the online directories. So we had some interns this summer, and we said, hey, you want to do this project? And they were like really jazzed about it. And they're still finding a lot of inaccurate information, by county in the directories, and this is just sort of a little slide that shows what they're, what they fund. I'm not saying this is like the world's greatest systematic review, I wouldn't publish this in a peer-reviewed journal or anything like that, but just sort of like our little, rinky-dink intern studies are showing that there's still a lot of inaccurate information out there, and this is from this summer about provider directories. And then we did do 2 surveys because we wanted to make sure this was absolutely right. We did it, and then a law firm duplicated our study. We were really interested in that if you call your plan and complain to your plan about whether if there's a wrong listing of their doctor. And this is one of those things where if you set up a rule, if you're not clear about what the rule is, there's a lot of health insurance companies. Each health insurance company interprets what a directory dispute protocol should look like. So 3 plans are just awesome. They say, and from our perspective, just say, whoa, member is not responsible for the bill if we inaccurately have a doctor listed. However, the next set of plans really don't follow that great best practice, which we would recommend. Some plan tells the consumer to submit a claim and follow a grievance procedure, and we've had very hit or miss experiences with that. Another plan says, oh, you submit an appeal, not a grievance, and then you have to figure out what the difference between a grievance and an appeal is. Some plans just had no answer for the problem, and that was validated twice, so we spent a lot of time figuring that out. And then one plan said, oh, call Troy, call the department, call Doofus, and let them handle it, which is not compliant with their contract. So, that could be better, let's just put it that way. And then when we do call directly to the plans, which we did in 37 cases, only 3 times did the plans actually correct their provider directory. So I think consumers are not the most powerful advocate, in this system. And that's just, we have to face the facts that consumers probably aren't going to be the ones that make change. So I guess what we would say is just kind of bring it, I'll shorten this, is that, okay, we're getting there. It's great that the law's there, but the plans don't have a lot of incentive to clean up these directories. Providers also don't have a lot of incentive to clean up the directories. And when the consumers do report misinformation, the complaints just aren't really acted in a timely way, at least so far. So, we decided to take a look and see what, California and Texas do. Those are the other big states, right? New York, California, Florida. Florida's nowhere, by the way. So California and Texas basically said, in California, they said, look, we're furious about this. This is completely unacceptable. And they went out and started fining carriers. And they did big fines, $350,000 against Blue Cross Blue Shield of California, $250,000 against Anthem. And also under their law, if your provider has if the provider's incorrectly listed on the plan directly, consumer has a right to a hearing, which is just a great practice. And then in Texas, which is remarkable, we don't really think of this as a true blue state. It's super consumer protective. It's weird in appeals; they've always been ahead of us. Actually, on external appeals, this is an area where Texas is really quite extraordinary. They really like to regulate health insurance companies, and they say, look, if there's a provider directory error, consumer has to be held harmless. Work it out between the carriers and the carriers and the providers, and that sounds a little familiar. And we like that approach, and we're hoping that that approach from the law can be extended to this provider incorrect information stuff. So we would say that's the real fix that needs to happen in this law. 35% of our cases are affected by this incorrect information. That's serious from our perspective. We really want to give a shout out to Senator Hannan, who has put out a bill, 6363, which I think he subsequently dropped, unfortunately, that would improve the surprise bill law significantly. It would expand IDR to hospital emergency room bills, and it would expand it to most importantly from our perspective, ambulance bills. So we would love to see that, and big shout out to Senator Hannan. And that's it. If you have more information, I'd like to also quickly note Erin Webb, who answers and helps people with their medical debt every single day. She's like the hero in the room, aside from Emily and others who work on these things. Thank you, Erin, for helping me put this deck together and for helping consumers with medical debt in New York.
Thank you, Elizabeth. So I'll just ask you 2 quick questions before we go to Lauren. So it's clear from your presentation that the law's working, but that there are remaining pain points for consumers. And you pointed out that the New York law doesn't even cover an issue that's driving 35% of the calls you're getting. Consumers are giving incorrect network information from their about a provider. So it sounds as if provider directories are not happening, consumers are paying the price, and then your studies show that it can be pretty random based on whatever plan you might be in, whether you're held harmless or paying that price. So instead, as your study showed, it sounded like most of the plan's protocols were requiring the member to do more. So how can we make sure that any policy fixes do not further put the onus on the consumer?
Well, I mean, I think that's why we would argue that these, directory disputes or provider inaccurate information about providers really should be subjected to the same IDR standard and the consumer should be held harmless. So if a consumer, our consumers are pretty good. They take screenshots, right? They know, or they'll take, most often they'll have like contemporaneous notes or know the name of the person in the provider's office that told them that their provider was in, and then they find out they weren't. Let consumers argue their cases in front of a hearing, and maybe, or like California does, or let the providers and the people that are most powerful in the system are the providers and the carriers, not the consumers. They're the least powerful, and so having it be their problem and their fault when it's pretty clearly not seems just really unfair. And then the other thing I would just say is that it would be really great for there to be, we feel that, there could be more resources in the state spent on, regulatory enforcement. I think, both the Department of Financial Services and the State Department of Health, have had caps on how many employees they can hire, and it's really a struggle for the regulators. I mean, I don't want to speak out of turn on behalf of, I don't work for the state of New York, but I think, it would be great to have more resources at the state level to do this kind of regulation. It's really not for us to be doing it. It's very presumptuous, in fact, of us to look into this stuff, but we would love to see that.
Thank you. That actually sets up a bit my next question, because you did show some data on the remaining gaps in the law, but we're finding this out because of your chalk complaints. And you had also showed data on variation by plans and how well they're complying with or maybe understanding the law, but that's based on your own studies. So beyond your work and formal complaints that DFS is getting, we really do not have a lot of information about what's going on. So how can we get better data reporting?
Gosh, I wish I knew. I do think it's pretty interesting in Troy's slide. His numbers were a little different than ours, but not that different. He was finding that 25%, if I did a quick calculation, but it looked like 25% and 33% respectively of the cases that they were looking at were not covered by the law. I bet if the department looked at what those cases were that were not covered by the law, I would say a huge tranche, some of them will be those cross-border disputes and the ambulances, but I bet a huge tranche of them are the same. It's a surprise to the consumer that their provider wasn't in network, but unfortunately that doesn't mean that they're covered by New York State's surprise bill. And by the way, I think New Jersey fixed this because they called us up and said, I think you guys, your statute does cover the not being in the plan directory, right, Magda? We told them to do that. The consumers in New Jersey called us and said, oh, don't miss this big problem. So hopefully you guys got it right. And we've been trying to tell every you know, we were the first state to go, and we just didn't think about this issue. I mean, it seems like such a dumb issue, right? I mean, like, you wouldn't think you would be liable for a bill when it's right there on the planned, you know, website that your provider's in, network, so.
So New York has some good competitive spirit, so maybe we'll be first in the nation to clean it up. So Lauren, that takes it off to you to give us some national and state perspective.
Okay. I'm Lauren Adler from the USC Brookings State for Initiative for Health Policy. I guess my role here is to sort of, so I do mostly federal policy research, although on this issue, I do a fair amount of sort of technical assistance for states looking at the issue as well, and I'm sort of undertaking currently a fair amount of research with sort of large claims database to sort of see how prevalent the issue is, sort of what are the factors affecting it. Obviously, a lot of states don't have any laws on the issue. And then also, I think one of the big things we're trying to do is take a look at the impact of state laws on sort of the amount of doctors that are now contracting in network, how it's actually impacted contract negotiations between insurer and provider, and also sort of the charge master rate that's sort of been alluded to here, that is sort of a sort of made up number that providers kind of have as their sticker price, but pretty much only uninsured people or have network patients actually pay that price. And just to sort of preface, my sort of talk will sort of focus more narrowly on the sort of on the surprise out of network billing issue. I think provider directories are a very large problem, but to me it's a somewhat different issue, although a very salient one and a very important one as well. But just sort of why I'm not mentioning that, even though I do think it's a very important issue. So I think for my perspective, Troy sort of touched on this, but in my eyes, defining a quote-unquote surprise out-of-network bill is really any out-of-network emergency department visit, whether that is at an out-of-network hospital itself or at an in-network hospital and you see an out-of-network physician in the course of your care. I think that sort of, I think Elizabeth mentioned, that is the out-of-network hospital is a place that actually a number of state laws do not explicitly touch, just as a sort of a smallish thing. And then also, basically when you go to an in-network hospital, you choose your in-network surgeon or whoever the primary physician is, and then you're seen by an out-of-network, either an assistant surgeon or generally it's your anesthesiologist, the radiologist, pathologist, the RAPs, as RAPs, the first initial of their names. Someone called them the rappers, which seemed a little bit odd. So I think the other thing is that this is a pretty common problem nationwide. So there's been now 3 pretty comprehensive national studies that found that when folks go to an emergency department, about 1 in 5 people going to an emergency department visit get an out-of-network bill in the course of their care. So obviously a pretty significant problem here. Not all of the times are the doctor actually billing the patient at the end of the day, but these are a case where the doctor could, if they wanted to, bill the patient and try to collect, except for state laws are in effect. And then it also is, so even for your sort of elective, I'm getting a hip replacement, I chose a network hospital, I did all my due diligence, I chose an in-network surgeon, I made sure of all of this, I double checked. About 10% of those visits, even you're getting an out-of-network bill from the anesthesiologist or the radiologist or something like that, or the assistant surgeon, which is pretty significant when you're thinking of a patient who did basically everything you could possibly ask of them to do correctly here. And I think sort of it's worth taking a step back right now to sort of ask why this problem exists. So fundamentally to me, this is, I don't think this is the fault of providers or insurers per se. It is a sort of a problem with the incentives here that there is no patient choice for emergency physicians or for the ancillary, either anesthesiologist, radiologist. There is no patient choice in this case. They choose their primary doctor. They don't choose their ancillary doctor. Obviously, in the case of an emergency, the patient is never actually really choosing their emergency physician. And also, they don't have enough information to know that this is a problem to police their insurance company or the hospital to sort of force this to happen, which would be the other way around, the sort of lack of choice. And as a result, so in a normal insurer-provider negotiation, the general thing is the insurer basically is offering, if you contract with me and you give me a price discount, I'll basically funnel more volume your way. However, for an emergency room physician or an anesthesiologist, that is not the dynamic at play. I'm an anesthesiologist, I'm an ED doc. I see the exact same amount of patients, more or less, whether I'm out of network or in network, because people are still gonna see me no matter what. And that sort of gives me the, I can charge whatever I want, basically. I can sort of charge through the roof in my charges, and that makes it hard to contract. And that is sort of it sort of requires regulatory or legal action here. And I don't think there's actually a way around just sort of hoping people are quote unquote good actors or ignore the tenets of capitalism. I think so. In my eyes, there are pretty much when you talk about a solution here. I think pretty much every state is actually there's two broad categories of solutions, as I would call them, and almost every state has taken the first one I'll go through here or some form of it. So basically, the first thing is taking the patient out of it, requiring the insurance company to hold the patient harmless and sort of treat it as an in-network charge. I would say I do think it is one where the New York one is a slight critique on the New York one is the patient effectively has to sort of start the dispute in New York as opposed to most other states where the patient the patient doesn't have to do anything. They might still get bills, they might have to do something, but that's a legal requirement of the insurer provider to handle this on their own without the patient having to do anything. It sounds like in New York, I've talked to a lot of folks around here, it sounds like that often happens. The insurer gets a bill and the insurer sort of initiates it anyway, even though there's no technical requirement to do so, because the insurer sort of has, right, they're sort of the patient's agent and kind of want them to not get this huge charge. So there's that, and then there's the prohibition so that the provider cannot balance bill the patient at the end of the day, and then you need to set up some form of payment from insurer to provider so that they're getting paid something. And then, so there's basically, you can either set a rate, however you want to set that, or you can set up one of these sort of binding arbitration processes like New York and New Jersey have, and Illinois and New Hampshire have sort of a variation on that approach as well. But to me, actually, I think those are very similar. It's just a way of defining the payment. And honestly, in a law like New York, where they're effectively telling the IDR what rate to use in the 80th percentile of fair health, it's not exactly telling them, but it is a guidance of the 80th percentile of fair health. I would suspect over time, I'm very hopeful that this does not happen, and it does not appear that it's happened yet, but I am somewhat fearful that the 80th percentile of charges, as I'm sort of talking about charges as being this very high rate, is that this will be sort of inflationary on what doctors have to pay these types of providers over time. Because it's just a very high rate compared to sort of your average contracted rates in New York. But inevitably, if you're actually providing guidance like that, I imagine it ends up at a similar place over time. New Jersey's is a little vaguer on sort of what they tell people. They sort of give them contracted rates and the expertise of the doctors. That one actually, the uncertainty might actually be helpful in some sense because it's unclear, and the provider and insurer might just sort of settle it out of court or out of IDR in order to avoid going to that process. And then I would just sort of briefly mention, this is a little more complicated, but the other solution, which no state has actually tried, although I saw an earlier draft of a New Jersey bill this at least get toyed with effectively, is you can just put the onus on the hospital also. So when most people, the problem here is when most people think of the issue, they think of it as that the hospital should not, there's no such, it's weird to them that there could possibly be an in-network surgeon, but the anesthesiologist is out of network. That just doesn't make sense to a normal human being. So you could just sort of force the hospital effectively that if you have any anesthesiologist, radiologist, any doctor at your network, at your hospital, you effectively have to just require them to be in network. But the way that it would work is you say, basically the hospital would start paying these doctors. So the way we pay nurses right now, for instance, right, you never get a bill from an out-of-network nurse. It's the same premise, right? The hospital pays the nurse directly, and then they build that into the fee that they charge the insurer. You could do the same thing with an anesthesiologist or an emergency physician. And honestly, that would be more logical for how folks think about this issue. There'd still be a sort of market negotiation between the hospital and the provider in this case to set a rate, and then they would just build that into the rate with the insurer. That's a little bit tougher when you get to sort of the assistant surgeon, which clearly is a bigger, very sizable part of the number of the IDR bills that are going to Troy there. Well, not to him, but so that may not be the solution for every instance, but I do think that is that makes a lot of sense, at least intuitively to folks when you talk about this. And then sort of quickly touch on, right, then the primary thing here is how do you actually set that payment amount? That's really kind of one of the fundamental issues here. And you sort of have three broad choices. So you can tie that payment to charges, as I mentioned, which is sort of the provider's sticker price that is pretty much untethered to any market force. So that is very high. Some very few states actually do that. And every state that has done it as an actual payment rate has seen pretty inflationary outcomes from at least what I've seen. It's pretty much Texas, Colorado, and New Jersey before their recent law to fix that. So you have that, then you can sort of tie it to some version of sort of whatever the contracted rates tend to be for that type of doctor, which is what every state basically has done. That tends to be the compromise. Provider come in with pay me charges, the insurer comes in with let me pay you Medicare rates. And pretty much every state seems to end up at some variation, almost every state seems to end up at some variation of let's pay something based on contracted rates. That is reasonable enough. I'm not going to prognosticate on which one is necessarily the best, other than charges is not good. Or you can do a Medicare rate and tie it to Medicare rates, and that doesn't mean it has to be low. You could tie it to 200% of Medicare rates, right? A lot of these physicians are getting paid, ED docs nationwide are getting paid 300% of Medicare. Radiologists are getting paid 200% of Medicare nationwide, same thing with anesthesiologists or more than that. So these types of docs are clearly getting paid much more than other specialists relative to Medicare today because of the sort of lack of choice. Your average specialist is getting paid like 125% of Medicare nationwide. I really don't know the New York data specifically, but there's been enough nationwide data on this to sort of prognosticate on that a little bit. So that's sort of I think there's sort of those three, or those are kind of your options at play. As I was mentioning, right, so there's now, in my eyes, I think there's about 9 states that have a somewhat comprehensive protection for surprise bills that at least covers the emergency situation and the non-emergency situation in network facilities. That pretty much breaks down. I think there's 4 states that I mentioned that use some sort of arbitration process, and then there's 5 states that just have a payment rule, which is New York, Florida, Connecticut, Colorado, and Texas. Sorry, I just named those wrong. California, Connecticut, Maryland, Oregon, and Florida. Those bottom ones are all the ones that have risks at play. Sorry, so but that is sort of an interesting, so there's now, and this is growing, right? Oregon passed one in 2017, Missouri did one for emergency billing last year. This is certainly growing on state dockets. It sounds like Troy is being brought in by other states to talk to them about what they did, and I find that a very good sign here. But as I was sort of saying, there are a few states that sort of tied to charges, which I think is something to be considering. And then I just sort of wanted to bring back to, right, I think at the outset we mentioned there are now, very recently, there were 2 federal bills that have been proposed, which is most of my day job is being in the DC world there. So there was a bipartisan Senate bill and then a bill from a New Hampshire Senator, Senator Hassan, that both took one took the sort of payment rule approach and one took the binding arbitration approach. But largely, I think the bipartisan one includes a few of the sort of more high-ranking members of Congress as well. I think this is a very positive sign, and as sort of both people alluded to, one of the biggest issues here is that state law is unable to touch the roughly half of people nationwide who are in these self-funded or ERISA plans, which is basically, it's almost any large employer plan. If you're a large enough employer, you sort of self-fund your health benefits rather than just paying insurance companies separately. So that really, at the end of the day, there's only so much states can do on this issue. At least from this sort of standard approach. If you regulate providers, you actually could sort of address the ERISA plan issue. So if you take that sort of, put the onus on the hospital, or to simply cap what providers can charge in this instance, you probably could tackle it a little bit more from the state level. But nonetheless, at the end of the day, look, not every state's going to act also. I think there's also an advantage to a federal solution from that level. And right, I think there is a lot of movement in Congress now. I think this issue is sort of, a lot of media has come to this, a lot of states acting, especially since New York acted. There's been a rash of new states. I think there were only a few states that really kind of had done, a lot of people had done emergency care, but not many folks have kind of gone beyond that beforehand. So I do think this sort of Cassidy et al. Bill is sort of a promising approach. I think they're still figuring out this sort of fundamental question of what actually gets paid in these situations. But I do think that's important. And then just at the end of the day, just to echo Elizabeth's sort of prods on the pretty much every state sort of seems to leave out the out-of-network ambulance issue as well. It is a little bit more complicated, and it's just so weird because a lot of cities have sort of found workarounds to the ambulance and ambulance issue themselves and like pay them. There's just every sort of locality handles their ambulances differently. They used to be largely provided by nonprofits, so it's a little bit more confusing. No. Well, I think it used to, actually, I don't know, maybe it doesn't. And then just the out-of-network ED. I also just, I do hold my nervousness on the tying to the 80th percentile of fair health charges. I do think in the long run, from my understanding, I've talked to a lot of folks in New York on the sort of insurance provider side. It sounds like there's not a great understanding of exactly what that rule is at this point. But I am fearful that if arbitrators actually start ruling towards that amount, providers will figure this out and they will start jacking up their rates and will start getting paid more and more. Fair Health even, they keep a database of average in-network charges as well, for instance, other databases as well. I think at least moving to that would be a sort of quelch a little bit of some of the inflationary risks at play in the New York law.
Thank you, Lauren. That was great. So I'm going to ask you some questions and then some questions for the panel, and then we'll open up to the audience. So you alluded to this, but some of the federal proposals that are out there or in the works, they make various decisions about how to price these out-of-network services, whether based on, as you said, an index of Medicare, or based on current in-network rates, or based on out-of-network charges. So in the course of trying to solve for surprise bills, are policymakers making some judgment calls about the current prices in the market? And are the politics around that going to gum up getting to a federal consensus?
Short answer, yes. I think that is the fundamental dispute that will make it very hard for federal lawmakers to actually pass something at the end of the day, unfortunately. They've currently made this sort of compromise of sort of basing around in-network charges, and maybe that's enough. The binding arbitration process is also, I think there's a political advantage potentially to it, because the Hassan bill, for instance, doesn't actually name a rate. So they don't have to make that difficult political choice, which from a political standpoint, that must have some advantages. The second you start naming an actual rate that is now the rate for these services, that's effectively going to become the rate for everyone gets paid. That's a very hard thing for policymakers to decide upon, and I know for a fact basically that I'm sure the Cassidy and Bennett and all of those folks are now getting an earful from both providers and insurers on trying to hash this out. I'm sure folks in New York dealt with this when they were in every state. This sort of seems to be there's a fight and you have to get the stakeholders together. I will say the fact that stakeholders have sort of geared up right now for the federal thing is actually a good sign in my eyes. In previous years, they never actually, the gearing up is a sign that maybe you're a couple years away from actually getting something done, which is better than 5 years away. So I do think we're kind of on the track, but I do think that fundamental decision, as you say, is going to be difficult.
Thank you. And another question, can surprise bill protections actually inject more competition into the healthcare market?
So from my perspective, I would certainly say yes. So I think it's at a fundamental level, right? You are right. You're making some decision about sort of what the right rate is, but part of the issue here is that we have the wrong rates negotiated in the market now, by definition, for these types of providers, because there is no real market force, because there's none of that volume price trade-off that exists in every good across the economy. So it's not just here. So we're sort of at the wrong prices now. I think sort of giving some onus can actually sort of help, right? And part of this is selective contracting, or sort of folks choosing, insurers using networks to steer their patients and to save money, is the fundamental way that we as a country have decided to sort of tamp down on costs to some degree. However, if the fact that you can sort of go to a hospital and see an out-of-network anesthesiologist and get surprised, that really undermines this sort of fundamental aspect of competition in our healthcare, and may turn people off of narrow networks or whatever it might be. It's not even clear that these are more likely to happen in narrow networks than none, but it is. I think solving that problem will sort of increase insurer competition effectively, and I do think sort of if you put the onus on the hospital, for instance, I do think that would effectively increase the competition among these types of providers. I don't think they would love that, because I think the data shows that these types of docs are generally getting paid higher rates because of a lack of competition today. So it means less money in someone's pocket, but I do think that would inject more competition into the system.
Thank you. So I have some questions for the panelists, for any takers, and then my colleague Laura is going to help us with a microphone and take your questions. So first, there seems to be a disconnect or incoherence between these calls for a federal solution to protect consumers against surprise bills and the increasingly laissez-faire, unfettered approach by the federal government to the public and private insurance markets. What are we walking into? Is this our future? And what does it mean for a state like New York and New Yorkers?
I'll start with just a quick federal thing. I feel like I've been talking for a while now, but yeah, it seems at odds with everything that there's definitely a deregulatory approach at the federal level towards insurance design anyway. That being said, right, there's 3 Republicans on this Senate bill. I do think there is some value. I do think there are a fair amount of Republicans who are interested in effectively making insurance competition more plausible, right? As I was just saying, right, you can't really have it really hurts insurer competition to have this surprise out-of-network billing issue here. And I do think there is sort of a very big pro-competitive markets thing. So I think some of them are coming from the markets angle. And I've heard sort of positive indications on this issue from pretty much everyone on the Republican side of the aisle, not everyone, But from a lot of people in DC on the Republican side of the aisle, so I am a little bit hopeful that this is viewed somewhat differently.
I mean, I would just say from the consumer perspective, consumers are so furious right now about medical billing. It's an outrage, and how consumers are treated, the fact that any hospitalization will yield 1,000 bills, maybe not 1,000, but anywhere from 5 to 20 bills that dribble in for months, years later. The fact that this medical billing statute of limitations in New York, for example, is 7 years, so that you can be liable for some random bill that you already knew that was out there for so long. And the collection agencies are so aggressive, they're willing to garnish your wages. I mean, it just goes on. And I think, one of the reasons why people look to single payer is they think, at least I won't get 1,000 bills. That starts looking more and more appealing when you talk to any friend of yours across any border. They are not subject to this kind of billing onslaught that does nothing for patients and consumers and does everything for the institutions that, and the moneyed institutions that are, have the incentive to keep it all very confusing and very opaque for consumers. And it just is unacceptable, and we've got to find a better way. It's just not fair.
And I would just, it is incongruous with what the administration is doing in many respects. We're fighting hard on recent Trump administration proposals around short-term limited benefit plans, junk insurance that threatens to flood the market with deregulated junk insurance that's going to steal the good risk, the healthy lives out of the insurance market, and the Trumpers will be able to say, look, this coverage is so much cheaper. Well, there's a reason it's so much cheaper. It's because it's junk and doesn't cover much, and people will get stuck with a lot of bills. I think that what we did see, at least in New York, that there was bipartisan interest in protecting consumers from surprise balance bills, I think simply because everybody has a district with constituents who complain, and this was a big issue.
Thank you. Next, I'm just wondering, how can we get better data? New York is planning to implement an all-payer claims database. Are there any ways that an APCD could provide insights into provider practices on balanced billing, or at least identify some of the outliers? I'm not a spokesperson for the APD, but
certainly the APD could be one avenue to get a huge amount of additional information on, at a real granular level about what's being billed and what's being paid. And obviously it could be really helpful.
I think the APD will also be really helpful because there's a lot of billing that's sort of nonsense billing, I would say, from the consumer's perspective. For example, our current bugaboo is this bill for a facility fee. What's a facility fee? Well, really, there's no medical service called facility fee, and yet our consumers are getting it. So, for example, we had a woman with her doctor said, part of the, I can't remember, I think it was maybe Mount Sinai Network, the doctor's saying, get your annual mammogram right here at Mount Sinai. And she's like, great. She goes in, she comes out with this is her free annual mammogram, which is a preventive service. There should be no bill, zero cost sharing. And yet she comes out, walks away with a $350 or $47 facility fee bill for this preventive care service that's her right to have free every year. So, I think it's just everything's a little run amok from the consumer perspective.
I mean, an APCD is certainly helpful, right? I mean, we have a fair amount of people, sort of private researchers, can get access to claims data, but an APCD is ideal, right? You can get actually all the payers. That's better than having just one or just two or just three payers. So I think there's a lot
Find out
of
what the facility fees are for.
Yeah.
And how many there are.
Well, I mean, so this is a sort of separate problem, but I mean, right, it's that hospitals are more and more just buying out independent physician offices with the idea that they can sort of charge, right, when a hospital charges, they charge a facility fee and the physician fee. And they, the facility fees covering their sort of overhead and all of that jazz. But when you're getting a mammogram or going to a primary care physician, that's a bit silly, but it is a good way to generate revenue for hospitals. So, but another issue, but an APCD can certainly get at all this and can get it with.
Tell us how many facility fees are being charged, what they look like.
Yeah, but it also can help for something like surprise billing, where if you want to know what sort of normal contracted rates are looking like, it can certainly provide an insight into that.
Thank you. So we'll take the audience questions. Laura will be walking around. You can raise your hand and please introduce yourself and your organizational affiliation if relevant.
Hi, I'm Sarah Rothstein. I'm the director of the 32BJ Health Fund. We're a self-insured health fund that covers union members and their families. We have gone to great lengths to protect our folks from surprise bills and emergency bills, all the best practices there, and then some. One of the things that we have noticed is that there's sort of an uneven distribution of where the surprise and emergency bills come from, even in downstate where you have sort of world-class hospital across the street from world-class hospital. We don't know why, but we find sometimes entire units being staffed with out-of-network physicians, being an entire emergency room that has out-of-network docs, ICUs that are being staffed entirely by out-of-network docs, some hospitals even here in Manhattan that are using out-of-network surgeons for their emergency plastic surgery. And it sort of raises the question for us about, what is sort of the social responsibility of hospitals and ensuring that care is provided in a way that's affordable and in-network when someone goes to an in-network hospital, and wondering what options the state has or suggestions that others have on how this can be approached.
I guess I'll start as the state. Certainly the network adequacy requirements is an obvious place to start, and I think one of the things we can work to improve on is our network adequacy standards as well as our enforcement around the networks. So we use a standard that the Department of Health has been using for many years, and certainly a number of you in this room have heard us talk about our interest in kind of updating that. But certainly certainly protecting consumers from surprise bills was a big piece of it, because that was obviously a source of a lot of those billings. But open to other ideas. Obviously, you're 32BJ, self-funded, not subject to New York State regulation. So no matter what we do, it's not going to really apply to your folks, as well as about half the commercial. Yeah. Oh, okay. Which is great. So and sort of dealing with the misinformation issue could certainly help in some cases. But I get your basic problem is there's certain areas of facilities where there's just no in-network doctors. Now, if you talk to the doctors, they'll say, well, if the health plans would just give us the rates we want, we'd be in-network. Certainly the health plans perspective, which I hear also, is these doctors are charging outrageous fees, and that all comes back into premiums, and the premiums are already way too high generally, but particularly in New York and even particularly downstate. And that affects coverage and competitiveness of our markets, et cetera. So one obvious solution would be the one Lauren's talking about, which is to require hospitals to have everybody in network, or you can't practice at the hospitals. I know, talking to Kathy sitting next to you and others have said that would lead to access issues, because they just wouldn't be able to get all the providers. But I don't want to speak for Kathy, but or the hospitals, but that's sort of what we've heard, because it was certainly one of the proposals on the table when we were talking about this bill. Why can't the hospitals just have everybody in network? Because it is, from a consumer perspective, really counterintuitive that you go to an in-network hospital and there's out-of-network doctors that are treating you. That's kind of messed up, right? But I also get, the hospital's perspective of they've got to provide these services too. So I don't have an easy answer.
I mean, I just jump in with, right, in a lot of the state negotiations, hospitals sort of try to stay out of it and say, this is between the insurer and provider. I think that's a little not quite clear, right? The hospitals are often exerting pressure on these types of physician groups to accept sort of at least the network rates from the major payers. The hospital accepts. The insurer is often at least trying to put things in their contract, trying to force the hospital to require those physicians to accept their rates. There is this interplay where the insurer pays the hospital to sort of make sure those guys accept your rates. There is a role that the hospital is playing here, right? The big problem, a big thing recently is we have all of these sort of new physician groups who, and sort of private equity companies who realized that there was a huge amount of money that they could be made here that basically ED docs and folks were leaving on the table. So folks came in and went, oh, this would be much smarter if why don't we go to the hospital and say, fine, don't pay us a stipend, but don't tell us to contract in network anymore, and we'll just go and we'll charge everyone out of network until they pay us 600% of Medicare or something, which is sort of the dispute between United and MCare right now, from what I understand. That is a lot of money. Insurers are obviously going to be a little bit hesitant to pay that, and you end up with sort of these issues where it's often that these, right, your ED docs, anesthesiologists, a lot of these folks often work in sort of physician groups that contract directly with the hospital for this. I agree that it is somewhat hard to make this for every type of provider, but from my perspective, I think at least for your ED docs, anesthesiologists, radiologists, and pathologists, I think at least for those docs, you could just effectively make them that the hospital has to pay them directly. Obviously the hospital doesn't want that. Obviously those doctors don't want that. I don't think it's in, they're scared that the hospitals have more market power and basically they'll get sort of their rates crammed down, but I do think they're more the client of the hospital. The anesthesiologist they can have a negotiation with the hospital that they can't have with the insurer because there's not the same sort of competitive forces at play. So I still think you might have some of these sort of external problems where you're talking about surgeons or ICUs that I think where you write a federal law is basically your option for kind of regulating payment in those circumstances.
And before I forget, I did want to sort of clarify the New York law, at least from the department's perspective, in terms of rates we're slightly off topic here, but just to address that. So from our point of view, the law does say that the IDR agent must consider the 80th percentile of fair health, but they may also consider any other information that's submitted, and I know that plans regularly do submit in-network rates, they submit Medicare, Medicaid, all that, and they're supposed to look at the totality of what's provided to them. But, I understand your point that like a set rate that's lower than 80th percentile UCR, certainly from a cost perspective, has certain appeal to it, and in terms of how that would play out on premiums. I also get from the doctor's perspective that's
it's right. I'm sorry, I tried to back away because I actually don't know exactly how it's private IDRs. I don't know exactly how they're getting rolled out, but right, that's the main point, right? At the end of the day, whatever we pay providers flows through the premiums. So at the end of the day, it is patients covering the costs of paying very high amounts for providers.
I was just also going to say that Sarah's question would have alluded to, and you mentioned MCare, so this is this outsourcing of these kind of emergency rooms, and Zach Cooper and Fiona Scott Moran's research has, detailed how that has really changed surprise billing in certain hospitals that are doing these outsourcing firms, and it's not just the surprise bills, but more like this pressure to do these kind of upcoding that has really inflated the rates all of a sudden. I think they said in the article it was as if a light switch was turned on. So that's a whole other issue we haven't tackled today. Any other questions? Well, the woman up front.
Hi, I'm Romina. I'm an office manager for an out-of-network provider. What we have seen is that ever since this law has taken into effect, the self-funded groups have, the self-funded insurers have really made their payments really very low because they now see that the doctors and the providers, they cannot go to IDR with self-funded plans. So they're sort of taking advantage of this whole situation, and the patients or the consumers are the ones who are all confused about it because they go to the emergency room. The emergency room tells them that, oh, it's an emergency, you are covered under the surprise bill law. And then all of a sudden they realize, oh no, I have a self-funded and the self-funded is not covered under this, and it becomes a huge thing. And so I think that if an insurance company wants to provide insurance to anyone in New York State, they have to be part of this whole IDR. They have to opt in because now you have a whole group of consumers, patients who are being hurt by this.
Well, personally, I totally agree with you that they should be complying with state law, but unfortunately, federal law, which under our United States Constitution, there's a supremacy clause, and they can preempt state law, and ERISA, the Employee Retirement and Income Security Act, does preempt state laws regarding self-funded plans. It's considered not insurance, and so state insurance regulations can't apply. So I wish that we need to change federal law in order for that to be the case.
It's just there's such a confusion too for the hospital, who doesn't know what self-funded is versus fully funded. The patient doesn't know, the doctor doesn't know until the bill is actually submitted. And also a lot of times when we call the insurance company to find out if a certain plan is self-funded or fully funded, they don't know. They can't tell us. That's a huge issue. I mean, I have girls sitting by the phone for half an hour, and the person picking up the phone still cannot tell them whether it's a self-funded group or a fully funded group.
Isn't there a bill saying that it's going to be listed on the cards? I think New York.
Yeah, it's something that Sean knows that we are. We're working on a regulation to identify on the member ID card self-funded,
which would make the CHA helpline so happy.
Thank you. I think, okay, thank you. And then afterwards, the gentleman in the back.
Caitlin Donovan, National Patient Advocate Foundation. I was wondering if there's anything in the law that protects patients from the bills being sent to collections before they enter into arbitration or even while they're in arbitration.
Yeah, under the New York law, and Emily jump in here at any point, but under the New York law, if it's an emergency bill, the health plan has to hold the consumer harmless, so the consumer can still be billed. That's a glitch in the law, I would say. The consumer can still be, or a loophole, whatever you want to call it, but the consumer can still be billed for the emergency services, but the health plan has to hold the consumer harmless from the bill. For surprise bills, once the consumer does the, makes the assignment, that's the word I was looking for, the assignment of benefits and signs that piece of paper, then by law, the provider is prohibited from billing the consumer anymore.
It's a special form.
So it's a special form that we provide notice, and the insurer is required to provide notice of it, and then once the consumer signs that assignment of benefit form, the provider cannot bill the consumer. So they couldn't bill them, they couldn't put them in a collection, they couldn't do anything along those lines.
I'll just tack on quickly, this is a little more national than New York, because I don't know. It's that every state has like sort of different ways that they can kind of regulate provider actions. In this situation, I don't know New York specifically, but at least in a number of states that have these protections, there's no actual penalty for balance billing the patient at the end of the day, or if it is, it's pretty minimal. And even in California, it's just you have to pay it back with interest if you get caught. a lot of the times, at least, there is no actual, right, so, you know, if you get caught, you have to make it right at least, but you don't have, there's no additional penalty, right? If you actually said, you get fined, you know, 25 grand or something like that if you send one of these bills and get caught.
The credit rating is
Yeah.
ruined, right?
Yeah, sorry.
You ruin a person's life, but no problem.
No, exactly. So I was saying, but if you have a penalty to the provider if they do this, or just make it illegal. I mean, it's a little difficult. I mean, all states have a regulatory apparatus over the insurer if they fail, and sort of, and pretty much every state has a way to fine insurers for sort of whatever they find wrong that they're doing. At least obviously it's more complicated than that, but providers are a little bit harder to regulate from and sort of penalize. So I do know that there are a lot of consumer complaints when I talk to consumer groups in particular, where a lot of folks are still getting balance billed even though there's a law, and most people don't know that there's a state law here.
Yeah.
And so some fight it, and some, but a lot of the especially it's like a relatively smaller bill. They just don't think of it and they're like, it's $150, it sucks, but like I'll pay it, rather than trying to figure out weed my way through regulations in the state government. Not that that's very helpful. Sorry.
Good afternoon. My name is Carlos Jativa. I'm the CFO of Gordon Structure Group. We're an out-of-network provider. Obviously, ever since the implementation of the surprise bill law, one of our goals is always to be compliant with the program and work with patients. Just an example, when a patient gets a deductible for going out-of-network, we often work with the patient, help give them the surprise bill form, and oftentimes the insurance companies, when they understand it was an emergency case, will cover 100% of the deductible. So our goal is always to be compliant and not be the practice that gives these patients the surprise bill issues. But one of the things we found with the IDR process has been it's been really geared kind of toward lowering reimbursements in a sense that even the way it's really been inconsistent in the sense of, for one example, the methodology used has always been, in last year we won an IDR, it was based on one number on Fair Health, and then we did the same practice, we adjusted our billing to be very close to Fair Health, just so we would always be considered reasonable. And then they said, oh, we changed the number, now we're using this new number. So it's, even as a provider, it's hard to understand what the exact system is. And what we've been told by all three of the IDR companies that we've used was basically there's really no negotiation. It's whomever's closer to Fair Health, and then they'll do a little bit of adjustment, is the winner. And we've had that in writing. They said, so if you bill $800 and Fair Health is $500 and they pay $300, they're going to say, well, they're closer to Fair Health, so and they paid $300, then the $300 bill stands. And our goal, I understand for the outliers that are way out there, our goal is to try to adjust that. And it seems we're basically chasing IDR every time they publish new numbers. It's like, oh, we got to adjust our billing, just so we're always saying, consider reasonable. If it goes low, then we'll lower our billing. How do we get that so it's not this fluctuating number, and the standards are basically geared as you mentioned like a baseball style. It pretty much seems it's winner takes all on whomever's closer.
Well, I guess that's me again. So our approach as regulator is to follow the law and let the independent dispute resolution entity make the decision. It's not for us to dictate what the final result is, other than did they comply with the law. And as I said, the law requires them to consider UCR, doesn't require them to award UCR. They can base it on whatever they think in their best judgment is the correct number, and they may consider any information submitted by the doctor or by the health plan. And I know that health plans regularly submit a variety of information, as do providers, and they may submit information about how that they're more experienced, the provider's more experienced than others in the field, etc., and so should be paid even more than UCR. The health plans may submit their in-network rates or other rates and say that we think these are the most reasonable. So we haven't tried to standardize or dictate what the IDR entity pays, other than we've told them to consider all the information that they're presented with. And I get what you're saying, which is, well, sometimes those are inconsistent results. And I think Romina's sort of made the same point to me earlier today when we were talking. I don't think I'm open to hearing input, but I think our position has been it's not up for us to dictate what those what the specific rate should be.
I just have something to add to that in regards to that. Can I add?
I think we'll do a few more questions.
Okay. The only thing that I.
The gentleman
Oh,
over
sorry.
there, thanks.
So this is a question for the state. First, my name is Derek from Community Health Management, a patient advocacy group. So when we have patients that have received surprise bills and perhaps the bill's already moved to collections, is that still appropriate to use the assignment of benefits form, or what is the best process in those situations?
Yeah, you can still use the assignment of benefit form, and happy to help in whatever way we can. And so, feel free after this to talk to either me or Emily about, other ways that we can help. But short answer.
More questions?
There's somebody.
Oh,
Audrey.
yes, Marjorie.
I want to commend everybody for a wonderful presentation, but as I'm listening to the issue and hearing when it's raised, so much of this is an after-the-fact battle between the consumer and the provider and or the hospital. And I'm wondering on your thoughts of how to bring this upstream in terms of consumer information, consumer education, that kind of empowers a consumer to be active in that first engagement, so that there's less of this after the fact battle that affects so much of the kind of consumer's financial history down the road. I'm looking for ideas.
Well, from my perspective, it's almost, respectfully, it's almost the wrong question. The consumer's the least able, it doesn't matter if they have information or not, they're never gonna be able to understand what a negotiated rate is easily. They're never gonna understand, 120% of Medicare. They're never gonna be able to understand all these sort of complicated medical billing terms and who's doing what. So I guess from my perspective, what we really need to do is take a good hard look at the whole patient billing system. And I'm hoping that, that is an area that at least my organization is very interested in getting a lot more deeply involved with. I think we have some ideas about that, which I'm not ready to share, but we've been doing some pretty deep thinking, and we think that the whole billing system really, we need a better way. And so we can talk about that some more offline, Marjorie, but if you're interested.
I appreciate that. I guess I'm looking at more of a consumer insurance bill of rights, that in the same way that folks have that for payment in the hospital, something that's posted or available that equips folks to know about the surprise bill, rights and laws and that stuff.
Yeah, Elizabeth Rosenthal's done a lot of work in this area, and she is very interested in starting an organization called We the Patients. We're very interested in hopefully starting the New York chapter of that organization. If that can work out, would be great. And we have some, we should talk because we have some really good ideas, I think.
Just to I think Elizabeth's framing is mostly right. There are some small things, right? Yeah, I think on the margin, right, having more accurate provider directories can help, but there's still fundamentally, especially when you're talking about the anesthesiologist, how can you plausibly expect a patient to call up the hospital and ask that the anesthesiologist is in network, and also the hospital generally can't answer that question because it's whoever's on call when you come in. So I think at some level, but I think the main thing is that you create a law that just automatically takes the patient out of it, so that the second the bill comes, the insurer has to step in, and the consumer doesn't even know that anything's happening.
Full commentary.
We're gonna wait for the microphone.
This is more of a commentary. I represent the facility fee.
Do you want? What facility are you at?
Mount Sinai. So, what a lot of things about transparency, and that's a key word, and that's another word that's being pushed out quite often these days. One of the things that the surprise bill statute addressed was transparency and a provider's obligation to post their affiliated networks online, as well as the physicians groups that we deal with. So a lot of the information that is required to educate the patient, it's there. If it's bare bones, we can all get better at it. A lot of the obligations for providers to communicate to the patient regarding the self-pay component of their bills. And nothing was mentioned today about the co-insurance, which is a major component of a lot of bills. So, I mean, is there any deductibles are excluded, co-pays are excluded, but not co-insurance, which I found very unique. Is there any plans to address that?
Next panel, so we'll do maybe for the future. So I just want to, while we're waiting for more audience questions, I was just going to ask our panelists. I know Elizabeth just alluded to medical billing issues, and so I'm also curious from the panelists, you know, what do you see coming around the corner? What are other emerging consumer issues do you see based on, I know DFS, you get a lot of consumer calls, and you know, what's on your radar, and I'll ask all of our panelists what they see.
Yeah, what? Tell us, Troy.
Well, you know, in terms
dental, that's on our radar.
Are you talking big picture or related to this issue specifically?
Beyond surprise bill, big picture.
Well, certainly one of the things we're really concerned about is making sure that the individual market remains viable, and you know, we've made some huge gains in New York where we've brought the number of uninsured down from, you know, around 10% to around 5% of the population, which is, it's a really impressive and great thing, and been an effort by, you know, from all the major stakeholders and certainly state government, and that's of course under threat, not just the repeal and the replace, but loss of the individual mandate penalty, and all, like I mentioned, not just short-term limited duration plan proposals by the Trump administration, but association health plans and other proposals that really are aimed at weakening and undermining the gains that we've made from the Affordable Care Act. And so I think our major focus, first and foremost, is how do we preserve and even expand coverage in the face of, and build on the successes that we've had in the face of really a hostile Trump administration that's doing everything they can to really undermine the great work that we've done.
The clouds have parted.
Yeah.
Good sign.
Can I jump in on this? I think, you know, we at Healthcare for All New York and the Community Service Society are also really eager to work on that remaining 5%, and we've been pushing very strongly for coverage for the remaining, those immigrants who are ineligible for either the essential plan or being able to participate in the exchange with the qualified health plans and the advanced premium tax credits. So we, you know, for a mere $532 million, New York State annually can cover, you know, its immigrant residents, which would be great. The other thing that we've been kind of running some numbers on is how much it would cost to even make the subsidies a little more affordable for people. Once you're over 200% of poverty, there's sort of this big cliff, and subsidy coverage ends up being, you know, anywhere from $100 to $500 a month for folks as you kind of climb up the income ladders, and it can be quite expensive for people, and especially faced with whatever it is, a $1,600 deductible for the silver product. It's just not a value proposition for lots of people, just over $25,000 a year. So we're looking at, you know, we've been really trying to push the state to consider doing a state-funded premium assistance program that would augment the federal tax credits. And then last but not least, if you're just talking about like what we're seeing on our helpline, honestly, dental is our boogeyman right now. A lot of people sign up for dental coverage and think they're getting some, you know, great coverage, and it can be very discouraging for people to actually use it. A lot of dental plans have waiting periods, pre-existing condition rules, you know, don't cover for procedures that you would think would be covered, and it's been a very frustrating experience for many, many patients, and we're trying to get our look under the hood and try to figure out better what's going on there. We're really excited that our partners at New York State of Health have decided to make it a little easier to enroll in dental coverage by doing some transparency efforts to sort of, so you can really do apples to apples comparisons across the, I think it's 9 products on the New York State of Health, maybe 11, something like that. You know, it's a good, cool, almost a dozen. And so that's really, really helpful because then people have a better sense of what value they're getting. Again, California's done some interesting things with thinking about doing minimum medical loss ratios in dental plans and, kind of looking a little more carefully or having a disclosure of what medical loss ratio or the actuarial value for the dental plan is, which I think would be a great, if you're really thinking about doing consumer transparency, if everybody understands 0 to 100, people understand percent. So if you could just say, oh, this dental plan pays for 70% or 80% or 90% of your costs, that would be very helpful for patients.
I think some of this will sort of be repetitive to some degree, but I mean, most of my work focuses on Affordable Care Act issues, so I think much of it in New Jersey here as well, just having passed a bill. I think the two biggest threats are basically trying to stop at the state level the sort of proliferation of short-term to limited duration plans, association health plans as well, but I do think the short-term plans are the notably larger risk to state markets. And then I also am, we work a lot with certain states, and we, and for one of our colleagues in particular, do a lot on sort of states can enact their own individual mandate to replace the federal government's. Obviously, that is not always the easiest thing to do politically, but there are a few states, who have, including New Jersey and Vermont, who have moved in that direction, DC, where I'm from, have moved in that direction. And I do think sort of adding back an individual mandate and sort of tamping down on the short-term limited duration plans would do a lot to shore up the markets. I mean, a lot of it is, right, I think we should, a lot of the sort of consumer protection issues would involve sort of building on the ACA rather than trying to tear it down. And I think I agree with, I sort of am more at the federal level, but I do think at the federal level, there is I think we've seen a pretty big need to expand the subsidies effectively in the ACA. I think the sort of, right, there were budget constraints and everything when the law was being passed, but I think we've sort of realized that no one likes a $3,000 deductible plan, which is sort of the run-of-the-mill for your individual plan in the non-group market, or $6-7 grand for a family deductible. And there's and it really is the cliff is after folks are making 200% of poverty, because below that we have sort of these cost-sharing subsidies, as they're called, to sort of help folks. Yeah. Oh, I'm sorry. And New York has a basic health plan in Minnesota too. But yeah, sorry. Sorry, I'm thinking too nationally, but it's a similar idea.
They're able to pride for us. We love our essential plan.
But it also gets to take that there's extra federal money to help the basic health plan because of the sort of larger subsidies nationwide for those folks. But nationwide, there's a similar cliff. Well, it's not quite as pronounced, but there's still a cliff nationwide on that level.
I just wanted to add, in case there's any doubt, in New York, we've already acted to make sure that none of the federal changes regarding allowing short-term health plans, limited duration health plans, those junk plans, or association health plans can be sold in New York, and I will just say, woe unto somebody who does that.
Yay! We feel warned.
Any other questions in the back? Yes.
Hi, my name is Sonia, and I'm from Resources for Humanity, which is an agency that I run regarding healthcare enrollment, which I've been doing since the inception of the ACA plan within New York. And my question is, you have spoken on advocacy, and I would like to know what percentage of the component within the Navigator program is being utilized as advocacy for the bill? And in the future, will there be any trainings involved with the Navigator program to get the information out there?
I think it's pretty, we're all, CSS also runs a Navigator program. Do you mean like an Affordable Care Act insurance enroller Navigator?
No, there is, within the Navigator program, they have different components that you have to comply with within the Navigator program. And one of them is advocacy, and then they have outreach, where you have to get the information out there. And what I'm asking is that, I'm suggesting that maybe within that program, that as part of that advocacy, that you can get the information, have a training program within the Navigator program to get the information out there. As part of not only the enrollment process.
No, because we don't have advocacy funding.
I'm sorry, I don't think in the state Navigator program, which CSS does participate in, there's no funding for advocacy or outreach. The funding has to be spent on, people enrolling folks in coverage, and pretty much. So I don't think I think the state has its own ad budget, and it's very well, actually, Sarah, you used to be very involved with all this. Maybe you should be answering this question instead of me. But I mean, I think I'm right about this, right? I mean,
I am involved in
Been
it.
a little while, but memory serves correct.
yeah. So okay. So maybe we're talking about a different program. That's the only thing I can think of.
No, we had, when I first started doing it, and currently we had budget funding within, and within the program where we did the outreach and the advocacy. And that was part of the grant that we had. I don't know if something changed, but where I worked and in the nonprofits that I worked with, we did that on the ground. And that was part of getting the information out there regarding the ACA and also the enrollment and what was involved in enrollment and getting the information out there.
Outreach training.
Oh, thank you. Any other questions or comments? Gentleman right there.
Thanks. Thank you all for being here and for this very informative panel. My name is Mike Fiedler. I'm with New York City Department of Social Services. A little bit outside of the scope, but kind of going on the same topic of market affordability and sharing up the individual markets. Given the recent release of the 1332 guidance last week and the also proposed regulation on HRAs, I was wondering if the panel had particular views on how that might play out nationally and in New York.
I'll take a first crack on the national, and then folks can chime in. So I think the 1332 waiver, so the new regulation was issued, new guidance was issued last Monday, I think, on 1332s, which basically says, it basically lets states sort of wiggle their way around it, it allows them to sort of rejigger the subsidy structure in a lot more lenient ways than used to be allowed, and it effectively would allow you to move your subsidies from lower income and less healthy people to higher income and or more healthy people effectively, which is sort of, that used to not be allowed. I don't think New York is about to start trying that, so I don't think in the New York State that is particularly a risk here. Nationwide, I think that certainly is. Somewhere like Iowa, for instance, already had a waiver, got denied by the Trump administration last year, would have effectively changed. So right now the ACA subsidy is based on it's pegged to the premium of the sort of benchmark plan and also to someone's income. If the Iowa plan just would have had flat subsidies to everyone, if you had flat subsidies to everyone, a flat dollar amount, you would most likely see the sort of ACA compliant market dissolve. Because basically right now, because the subsidies go up dollar for dollar when plans increase their premiums, sort of keep some of the healthy folks in the market, especially in the subsidized range. I am very fearful about the long-term effects of this. The fact that it would completely unravel some of the markets, hopefully that will get through to other state policymakers as they are toying with this issue. I can't promise that will be the case. There may just be sort of more minor things of sort of shifting money around from sort of the ACA was a huge transfer from healthy people to sick people, and from taxpayers too, and sort of mostly from higher income taxpayers to lower income people. This would allow you to do some of the reverse of that. The HRA rule, I'd actually be a little bit curious to hear what Troy says, because I do think, I'm still sort of trying to digest the rule from a legal perspective, but it does, the risk here is that you would have employers sort of cherry pick their, the regulation that got issued, the idea is that it would allow employers to offer basically a dollar amount to their employees to then go buy health insurance in the individual market, as opposed to offering sort of a plan like most employers do today. The really sort of bigger risk here is that they would cherry pick just their sicker employees, and it would be a win-win from both the sort of community-rated ACA market, be a win-win for the employer and the employee, but would be a very big lose for the individual market and all the folks who are paying the premiums there. The law, the regulation, the proposed reg does include a fair amount of protections trying to limit the ability of employers to cherry pick in that case. It's still kind of, you still have the firm-specific risk where a single firm with all sick employees might be willing to do that, but I do think that is much less of a risk than if every employer started trying to cherry pick their sort of sickest employees and did this. But I am not 100% sure, and one, this is a proposed rule, so it is very possible they weaken some of the safeguards in the rule as final, and you can tell in the bill, they sort of ask, in the proposed regulation, they ask a lot of questions, should we weaken these safeguards? And I am very fearful they end up doing that, but I'm sort of curious what the New York regulator thinks on that one.
So I guess taking them in reverse order with HRA, we're still looking at it and been talking to some other colleagues in other states, and we will be submitting comments to the Fed, so I don't want to
we will as well.
announce what we're going to say exactly, other than, I think we want to reach out to our plans and to other stakeholders, but share your concern about the impact and the potential for cherry picking and what that will do to our markets. Again, you know, primary goal of the department is preserving our markets. So, as to the 1332 waivers, we were looked very closely at them last year about doing a reinsurance proposal. We had worked very closely with our colleagues in Minnesota, who also have a basic health plan. Fred Anderson is their number 2 person. He used to work at the department, know him really well. And so we've been in constant contact with them, and it looked really good that they were going to be able to effectively have their waiver not unduly impact their basic health plan. It was a short way of saying it, and had all kinds of good indications from CMS that that would be a case. They submitted it, and when it was finally approved, they ended up getting not treated very well. Yeah, use a stronger language for that. Their governor wrote a very strongly worded letter to HHS, and so once that happened, we took 1332 off the table. Certainly the new changes that are coming about, again, I don't want to make, we're open to all kinds of discussions, but it doesn't seem to be the kind of thing that New York would want to do. Just say that. But,
Any other questions? Well, I want to thank our panelists and our audience. Thank you so much for your time today.